Hello everyone, we are Alliance 4. Today we are here to present our research on optimization of intelligent pharmacy service systems. Our study found three problems in hospital pharmacies. First, the current system mixes emergencies and regular patients in the same quiz, creating unnecessary delays. Second, we've observed a low pharmacist utilization at just 68% due to rigid role assignments. Third, drug shortages and slower response times further increase the delays. These issues result in an average 28.6 minutes wait time and a 22% emergency delay rate. To solve these problems, we propose a comprehensive upgrade. Through dynamic staffing, we enable real-time pharmacist allocation based on actual demand. Priority Triage creates dedicated pathways for urgent cases, while our smart inventory system uses predictive analytics to prevent shortages before they occur. These approaches can optimize efficiency and transform the pharmacist service to be more responsive and patient-centered. Then our group member will introduce the data of our research.
Our input analysis focuses on three aspects. First, we clean patient data via NHPV to estimate hourly arrival rates. Results show morning peak between 8 to 10 a.m. and the midday between 12 to 1 p.m. We also identify emergency patients by age larger than 70, or hypertension or diabetes makers, which accounts for 25%. Then, based on drug effectiveness and side effects, we use key means clustering prescriptions into low, medium, high complexity with target ratios 50%, 30%, and 20%. But actual distribution doesn't reach this, which will be refined next. Finally, we assume high-frequency drugs have 8% stock-out probability, others 3%, and replenishment time follows 20 minutes. And charts show that uniform stock-out rates and replenishment times concentrating 5 to 50 minutes. These insights lay the groundwork for optimizing triage, pharmacist allocation, and inventory management in model building.
Our model assumptions can be summarized into the following 5 points. First, emergency patients receive non-preemptive priority, automatically identified via virtual triage tags, and are inserted into the top 10% of the queue without interrupting current services. Second, pharmacist role switching requires a 2-minute preparation time. Third, stock-outs immediately trigger an automated restocking signal without manual intervention. Fourth, when the regular queue lines exceeds 5 patients, one pharmacist is dedicated exclusively to real tasks. Finally, a second emergency window automatically opens if emergency wait times exceed 8 minutes. The following block diagram simulation model describes the entire triage process by implementing dynamic priority queues and resources allocation in Arena. We use non-homogeneous Poisson process to generate patient arrival events. The parameters are set in segments according to peak and valley. In the triage system, we use if-then logical decision tree to categorize emergency patients and insert them into the fast track. In the queue and pharmacist allocation process, dynamic resource pools are used to allocate pharmacist resources based on prescription complexity. In the inventory inspection process, trigger the replenishment process when there is a shortage and restore inventory after completion.
This system transforms healthcare efficiency while serving urgent needs. Patients get faster emergency medication access with shorter wait times overall. Pharmacists see reduced strain through smart task distribution aligned with their expertise. Hospitals gain both improved service speed and lasting cost savings. Beyond healthcare, its priority-driven design solves critical resource challenges in banking queues and airport operations. The adaptable framework ensures urgent cases are addressed without sacrificing daily workflow sustainability. What we are presenting today is more than technical innovation. It's a blueprint for building crisis-ready systems across industries. This concludes our proposal. Thank you.